So this algorithm explains the management of endometriosis. First of all, if you have a suspected case of endometriosis, which means that you have a patient with the symptoms like chronic pelvic pain, dysmenorrhea, deep dyspareunia, and dyschezia. So if a woman presents with any of these classic symptoms, you are going to suspect endometriosis. Chronic pelvic pain, especially around the menstrual cycle, dysmenorrhea, which is painful period, dyspareunia, pain during intercourse, and dyschezia, painful bowel movements during menses. We are going to ask few questions before deciding the next step. First of all, you are going to ask, does she need a definite diagnosis? For example, if you ask her that does she need a definitive diagnosis? For example, she is having infertility or we need to rule out cancer. Then you can ask that is there any concern for malignancy or adnexal mass? Then you can ask that does she have contraindications to hormonal therapy? For example, she can't take oral contraceptives due to clotting risk. Then you can ask, is she willing to try empiric or non-surgical therapy first? So you ask these few questions before deciding the next step. Let's suppose if she says no to these questions, like she's like there is no contraindication to the medical therapy, there is no need for the definite diagnosis, or she's not suspecting any cancer or malignancy or adnexal mass, and there is no history of infertility. So if her answer is no, that means that we do not urgently need surgery and there is no concern for cancer. So we can simply start with the medical or empiric therapy. You can give answers for pain control, plus you can give oral contraceptives to suppress the ovulation and endometrial proliferation. This is called the empiric therapy because you are treating based on the symptoms without confirming diagnosis surgically. Clear?
Okay.
If you have started this empiric therapy and the patient's symptoms are improved, you can continue the therapy. But if you have started the therapy and the patient's symptoms are still persistent, now you have to move towards the diagnostic laparoscopy. On the other hand, if the patient says yes to the answer, which means that she need a definite diagnosis or fertility evaluation, or you have concern about a mass, so the next step should be laparoscopy. During laparoscopy, you can visualize endometriotic lesion directly. You can excise or ablate them to relieve pain and improve the fertility. Clear?
Okay.
So, a few things you need to remember. The first line treatment, medical treatment is NSAIDs plus OCPs. The gold standard diagnostic test is laparoscopy with visualization and biopsy. And if they ask you about the definitive treatment, particularly for completed family, you pick the option total hysterectomy with bilateral salpingo-oophorectomy. Clear?
Yes.
Then we have this algorithm explaining approach to postmenopausal bleeding. If a patient, first of all, you have to identify the clinical problem. Any bleeding that occur after menopause which means if there are no periods for more than or equal to 12 months, and then there is some bleeding, that is considered as abnormal until proven otherwise. The main goal of evaluating postmenopausal bleeding is to rule out endometrial cancer. So the first step you are going to do is to do transvaginal ultrasound and measure the endometrial thickness, the lining of the uterus. This is safe, quick, and non-invasive method to decide who needs a biopsy. So if you have done the transvaginal ultrasound and your interpretation is endometrial strip is less than or equal to 4 mm, there is a very low risk of cancer, so you can simply observe the patient. No biopsy is needed until bleeding reoccurs. But if the endometrial strip is above 4 mm, there is a possible risk of hyperplasia or malignancy. So now you can go for endometrial biopsy to rule out or to look for atypia or cancer. And if so, basically, when you interpret the biopsy, and then when you interpret the biopsy, if the biopsy results are benign or normal, then you can simply observe the patients. It could be atrophic endometrium or hormonal changes. So observation reassure the patient, and no further action is needed unless bleeding reoccur. But if the biopsy results shows atypia, neoplasia, or endometrial neoplasia, it it will give you a clue for a precancerous or cancerous lesion. Now you have to treat the patient. You put the patient on progestin therapy if fertility is desired, or no surgic or if a patient is not a surgical candidate, then you put the patient on progestin therapy. Otherwise, if they ask you about the definitive treatment, then definitive treatment will be surgery or hysterectomy. Clear?
Can you repeat the first step?
The first step is you will evaluate the postmenopausal bleeding, and you have two options. The first option for if the first option is you have to do the transvaginal ultrasound to look for the endometrium size, to check the endometrium size thickness, sorry. Because this is safe, this is not invasive, so you usually start with the transvaginal ultrasound to look for the endometrium thickness, and then you proceed further. If you are confused that when we are going to do endometrial biopsy straight, we can go and do endometrial biopsy straight if the patient is having, if the transvaginal ultrasound was already done and the size of the endometrium is increased and now the patient is on follow up, or if the patient is having bleeding for a very